Good afternoon, or hello everyone, and welcome to the Rural Emergency Hospital Education and Fireside Chat. We are here today with a former CEO of a rural emergency hospital. My name is Candace Talkington, and I am going to be your moderator today. We do have a packed agenda. We're going to start with just giving you a brief overview. If you've joined us before, you may have seen some of this information, but if you are not familiar with the REH, we're going to give you a brief overview of the policies and requirements of being an REH. We're going to talk a little bit about the Rural Health Redesign Center and the technical assistance that's available to all of you. And again, we're going to have a fireside chat. Janice Walters is going to be leading a chat with Jeff Bowman, who's the former CEO of South Central Kansas Medical Center, which is a current rural emergency hospital. And then we'll close out today with some resources and next steps. As always, with the Rural Emergency Hospital Technical Assistance Center, this work is funded by the Health Resources Services Administration, known as HRSA. Again, we have with us today Janice Walters. She's our Executive Director here at the Rural Health Redesign Center. We also have Anna. Anna is the Program Director at here at the Rural Health Redesign Center for the Rural Emergency Hospitals. And then me, I am Candace Talkington, and I will again be your moderator for today. Just introducing Janice. Janice is a highly rated rural health expert with over 20 years of leadership and healthcare finance experience. She works closely with rural health executives, state, federal programs, and other community partners to ensure rural communities across the U.S. have access to quality health care. Janice has overseen technical assistance programs, including the Pennsylvania Rural Health Model, as well as Technical Assistance Center for the Rural Emergency Hospital and the Rural Northern Border Region Healthcare Support Programs. Anna is a nurse executive and previous Critical Access Hospital CEO. She's a transformation leader and enjoys working with rural hospital leaders to innovatively maximize the impact of the communities as they serve. Anna joined the Rural Health Redesign Center in November of 2022, and in addition to her role as a senior leader, she is the program director for the Rural Emergency Hospital Technical Assistance Center. Before we get started and dive in, just a few housekeeping items to keep in mind. You may notice that you're all on mute. This is just to prevent any inadvertent background noise. When possible, we ask that you use the webinar link to log in rather than just using the audio portion. This will just ensure that you have the best quality experience. We do encourage you to ask questions. Many of you submitted questions through registration. We have forwarded those on to our guests today, and we'll be happy to introduce those questions to Jeff towards the end of our presentation. But if you have other questions, please feel free to use the Q&A feature. You'll find that either at the top or the bottom of your screen, depending on your layout. We do not have any polls in today's session, so you're off the hook there. But if you have, again, just encourage you to use the chat or the Q&A for questions. If you need closed captioning, that is available to you. To access that, click the three dots on More, and then select your language, and you will have the transcription option for the closed captioning. Slides and recording will be available on our website, rco.org. I believe the slides are actually already available, so if you want to go out and grab those, you can. The recording will be available within 1 week after today's session. If you have follow-up questions, you can reach us at rehsupport@rehco.org. All right, just to go over our brief objectives today, giving you a high-level overview, talking about REH policies and requirements. We also hope to have you learn a little bit more about us and the technical assistance that we're offering to the rural emergency hospitals, and describe some of those services. And then again, most of the portion today, we're going to be talking with Jeff Bowman, our former CEO of a rural emergency hospital. So with that, I'm going to turn it over to Anna, who's going to give us the brief overview of the REH, and then also talk about the technical assistance that we have available here at the Rural Health Redesign Center. Anna. Welcome.
Thank you, Candace. So as Candace said, we'll do a quick education on the Rural Emergency Hospital designation. So this designation was established by CMS as a new provider type on December 27th, 2020, and became effective in January of 2023. The REH provider type was created to give rural communities an option to operate hospitals as an emergency and outpatient care facility. The intent of the REH is to reduce the number of rural hospital closures and improve equitable access to care by offering innovative payment for emergency and outpatient services in the rural community. The REH designation is the first new rural provider type since the Critical Access Hospital was established in 1997. And to note, this is not a temporary or demonstration model. The policies governing the REH were published in the 2023 Hospital Outpatient Prospective Payment System and Ambulatory Surgical Center Final Rule on November 27th of 2022. So we'll talk a little bit about eligibility. For a hospital to qualify as an REH, the hospital must be in a rural area, licensed as a critical access hospital or a rural prospective payment hospital as of December 27th, 2020, with fewer than 50 beds. Must be licensed as a Medicare provider. The hospitals will need to meet staffing, training, and certification requirements. They also will need to meet an annual average length of stay of 24 hours. They also must meet state licensure requirements for the REH and have an established transfer agreement with either a level 1 or a level 2 trauma center. Also, the hospitals will need to attest that they are in compliance with the conditions of participation. There is an action plan that is required to be provided with the application process, and that action plan needs to specify the transition plan that the hospital has established, describing services that will be added, modified, or discontinued. So the services that an REH must provide include 24/7 emergency services and observation care, diagnostic lab and radiological services to meet the needs of the patient population that the hospital will serve. Pharmacy drug storage area and discharge planning must be available and overseen by a qualified professional. Again, REHs do not offer inpatient care, but are required to establish transfer agreements with other hospitals to meet the needs of the patient population. There are many things that a rural emergency hospital can provide on an outpatient basis. And this is not an exhaustive list, but as you can see, REHs can provide ambulatory and transport services, behavioral health services on an outpatient basis, of course, care through a rural health clinic, skilled nursing care in a distinct part unit, and low-risk labor and delivery services are also permitted. Outpatient surgeries, post-hospital care, primary care, routine laboratory services, and telehealth as well. This slide speaks to the payment structure of the Rural Emergency Hospital. I'm going to ask our Executive Director, Janice Walters, to go over this slide with you.
Sure. Thank you, Anna. So as with any change initiative, part of what has to be balanced is what we call the value proposition. And specifically for the Rural Emergency Hospital, it's really what you have to gain and weighing that against what you have to lose. So certainly to become a Rural Emergency Hospital, as Anna has already identified, certainly there's things that you have to give up in order to get the fixed facility payment. So, the premise of the REH payment is that you will get a fixed facility payment, a set amount per year of $3.314 million paid through predictable payments, in addition to an enhanced 5% bump in reimbursement on anything that's paid through the outpatient fee schedule. Obviously, what you have to give up is really closing your inpatient services, closing your swing bed units. 340B is currently not eligible to rural emergency hospitals. And then for critical access hospitals, you give up that cost-based reimbursement. So really, it's the balancing of what you gain in terms of what you lose. Obviously, our team is available to help with that financial modeling. That's one of the major things that we offer, is sorting through what all of this means from a reimbursement perspective, especially for critical access hospitals moving away from cost-based to outpatient OPPS reimbursement, as well as that fixed facility payment. There are a couple other notes on this as it relates to no payment changes to rural health clinics. No Medicare required changes to Medicare, no Medicare required changes to Medicaid, Medicare Advantage, commercial payers, etc. We like to make the point that this is a Medicare fee-for-service only payment arrangement at this point, and there's no changes to cost sharing for beneficiaries. So with that, Anna, I will turn it back to you.
All right, thank you, Janice. We'll talk a little bit about the application requirements. So on January 26th of 2023, CMS released additional details that outline the documentation requirements needed to accompany the REH conversion application and the guidance for rural emergency hospital provisions, conversion process, and conditions of participation memo. In the memo, CMS describes specific requirements for what should be included in the action plan, the transfer level 1 or level 2 agreements, and the attestation for meeting the rural emergency hospital conditions of participation. The action plan really needs to describe the services that the rural emergency hospital will continue to provide the community, the staffing, and what that transition plan looks like as far as services that will be modified or discontinued or added. So again, the hospital can have more than one transfer agreement, but they must have at least one with a level 1 or a level 2 trauma center. So we at the Rural Health Redesign Center Technical Assistance Center provide this work with the mission in mind to really protect and promote access to rural health care in our communities throughout the country, with a vision to help rural communities thrive through improved health. The Rural Emergency Hospital Technical Assistance Center, as hospitals reach out to us, we start with an introductory call to really understand the individual situation of the hospital and the needs of that individual hospital as far as education related to the rural emergency hospital process. We provide multiple tools for the hospitals as they are on this journey to educate their community, their hospital boards, and various stakeholders to make sure that the community still realize that these hospitals are there to continue the service that they want to provide to their family members, their friends, and their community. We also take them through the steps of the application, providing tools that will help with the development of the action plan and all of the steps and education needed to ensure that their action plan is as thorough as can be, to really help streamline the process and the application process. We also work with our hospitals on strategic planning and what that looks like as they transition their care from a critical access hospital or a PPS hospital over to a rural emergency hospital. And then the exciting part also for me is that we continue to work with these hospitals in the post-conversion realm so that we can really maximize and help them think about innovative ways that they can continue to expand their service and their reach into their community. So again, this is all technical assistance that is provided at no cost to the hospitals. And as you can see, there are some comments there from previous participants in the cohort that have appreciated the assistance that they've received. So the conversion process starts with as I said, a conversation to really determine eligibility. And then we work with those hospitals through a financial modeling process that, as Janice described, really paints a clear picture of what that designation change would look like in their individual community and for their individual hospital. Again, we support them through the application process, through the conversion process, and then ongoing as they transform their hospital into a rural emergency hospital. The timeline really varies per hospital. As we speak to hospitals, we discuss the sense of urgency that they have, and we do meet them where they are to provide this assistance individually. Candace?
Hi, Candace, you're muted.
Thank you. So very excited to have Jeff here with us. As I mentioned before, Jeff is a former CEO with the South Central Kansas. I'm sorry, South Central Kansas. I'm going to take control here just a second. Can't see my notes. There we go. Jeff is a former CEO of South Central Kansas Medical Center, a city-owned quasi-governmental entity since 2018, and with more than 2 decades of healthcare leadership experience. Jeff Bowman was instrumental in positioning South Central Kansas Health to be a viable and sustainable model as the first rural emergency hospital in Kansas. He is skilled at building relationships with physicians and staff and is known as an effective communicator and partner builder in the hospital and community. Bowman was able to double the number of hospital employed physicians, physician assistants, and nurse practitioners during his tenure. As a visionary leader, Bowman has successfully built healthcare organizations in the US and internationally by driving innovation, operational excellence, and strategic collaborations. He is recognized as a collaborative healthcare leader with the ability to strengthen strategic planning and financial discipline while driving operational excellence, business growth, and exceptional clinical care. You can see why we've asked Jeff to join us, and we're very excited to have that. Leading us through this discussion is our Executive Director, Janice Walters. Janice, I'm going to hand it back to you to lead the discussion with Jeff. Jeff, welcome.
Thank you, Candace.
Great. Great. Thank you, Candace and Anna, for setting, I would say, the stage for this conversation. We really are thrilled to have Jeff here with us. As with any change, change is scary, and certainly based on Jeff's bio, you can see that he's dealt with a lot of change in his career. And again, just really thankful that he's willing to take the time to meet with us and just have a candid conversation. And so I do notice, if you think about the fireside chats, when you go to events, there's usually some nice cushy chairs sitting up there on the stage for folks to sit in. Looks like Jeff might be sitting on his sofa. However, I did not go get my big cushy chair to sit in. So just imagine, as you sit and listen to this conversation, imagine that we're, just sitting next to a fire and having a conversation. So a lot of the questions that we thought of, again, interacting with all of the hospitals that we have over the last year plus, we came up with some questions, but then also we're hoping to have time to answer questions that came in through registration, as well as anything that might be put in the Q&A. So if you move on to the next slide, I'm just gonna launch the first question and send it your way, Jeff. So, in your own words, from your experience, how has the transition to the REH designation affected your facility? Has it been beneficial based on what you have seen so far?
Absolutely, has been beneficial. We looked at working with you guys, doing the financial forecasting and modeling and trying to see and be as prepared as we could for the transition. And it has been successful for South Central Kansas Medical Center. The only thing we wished in 2023, we would have received the designation a couple months earlier, because then we would have been profitable. However, we did get the designation in September. And if we had gotten it in July, we would have been profitable. So we were just lost a few $100,000.
And may I ask, in comparison to what? So a few $100,000 in comparison to what?
The previous year was 3.7 million loss.
Wow.
Yeah.
Very cool. Very cool. Very good. Moving on to the next question. So what has been the most significant changes to your facility since the transition to an REH? So certainly as part of the application process, you're required to put together a transition plan, an action plan of what's going to change, what's going to stay the same, what are you, I would say, right sizing. So can you talk a little bit about what's been the most significant change to your facility that accompanied your transition?
Yes, so we had previously had an inpatient behavioral health unit that was very successful. The organization that ran that unit for the hospital, the leader had retired, and so they ended that in February. So we'd already made that transition. We also knew that our OB unit had been having some difficulties. We're about an 86% Medicaid, so we were losing substantially there. So we had already planned to close that unit in first quarter of 2023. So those were transitions that we made prior to the REH that we would have had to have made. The great thing was that we were looking forward to the future. The only difficulty we had was with our orthopedic surgeon. We've lost about 22% of his surgeries because some of them were inpatients. But that would probably be the most significant for the ortho in our change.
So can I ask you, what did you do in that situation? So is it you're not doing any inpatient or you've moved everything to outpatient? Like, how did you manage that specific orthopedic change in your community?
We honestly had the opportunity to work with a critical access hospital that's close to us, about 7 miles away. But through the change, they were going to do the inpatients there, but Dr. Ansari's outpatient grew significantly during this change. So we didn't have that need. He didn't have the bandwidth to be able to do those additional surgeries in another location.
So you were actually able to keep, I just want to make sure I'm clear, you were actually able to keep some of that orthopedic there just on an outpatient. Is that fair?
Yes, about 80% of his surgeries are outpatient.
Awesome. Very cool. Anything else you want us to know specific to that one?
Nope, I think we're good on that one.
Good. All right. So moving on. What has been the most significant challenge or barrier you have faced so far related to the conversion? And then subsequent to that, and how did you address those challenges?
We had done and completed community awareness previously, so that helped with some of the barriers, but we still had some of the confusion from individuals in the community thinking that, you know, we made a decision to send my mother to another hospital because we have changed and we're no longer a hospital per se. So it's still a little bit of education. Even if you do a lot of that up front, there's still going to be some kickback and misunderstandings. And we all know that necessary change is still change and everybody hates change. So that was part of, you know, one of our bigger barriers in the conversion.
So did you actually see in their early days utilization go down because of that? Like the perception of the community, like losing inpatient, or did your volumes stay pretty consistent?
The volumes were fairly consistent. The interesting thing is we have a city-owned EMS, and for about 2 weeks we had them bypassing us. So we had to, you know, educate them on what was going. Nothing's changed, everything there. So making sure that not only are you educating the community, but anybody like the ancillary ambulances and them, it's important to make sure that you educate them up front.
And how did you recognize that? So how did you realize, oh my goodness, EMS is now bypassing us? Was it just ED staff, or how did you recognize that issue early on?
Our director of nursing is very involved with the ED staff, and our team leader had already been tracking. We track the visits or the ambulances coming in and going out. So we had a system already in place, and we caught that within like 3 days.
And was there any, I would say, resistance from the EMS when you went back to re-educate them or further educate them? Any resistance there or not?
No, we had a quick in-person meeting, and we thought we would follow up with a weekly Zoom meeting. And ironically, it was resolved before we even had the second meeting. we still had it, talked about it, and we were all clear on how everything was moving forward.
So one more question, just because we've heard, some hospitals are struggling with this, EMS is now bypassing, impacting utilization. So how were your relationships with your EMS prior to your conversion? Did you have strong relationships with them, or were they somewhat strained before?
We've had very strong relationships because it's a city-owned ambulance as well as city-owned hospital. So we've always worked closely together and understood the significance of supporting each other.
Very good. Thank you. So if we move on to the next question. So thinking about what Anna talked about and the role that we've been asked to play in this conversion process, can you speak a little bit to, first, were our services value? If so, how were we most helpful to you on this journey?
Oh, goodness. So we had started our due diligence in October of 2022. And as soon as we found out about the Rural Health Redesign Center, we reached out, had the introductory meeting. We were in the cohort 1 group. We had the group meetings. Then we turned and we had individual conversations with Anna and a previous hospital CEO. We had Mathematica that did the financial modeling. So we had already contacted our auditors, and they started it. And then we started with you guys. And I felt like the Mathematica modeling was a little more robust, if you will, but we had ample information to be able to make an informed decision to see how this is going to change our hospital to being viable and sustainable for the future.
Is there anything we could have done a little bit better for you? So we're always in the spirit of learning, and it's okay if you list 3 or 4 or 5 things here, Jeff. How are there things that you think, man, it'd be great if somebody could come in and do this for me, that maybe there was a perceived gap or there is a gap? Anything there that you would provide as constructive criticism, constructive feedback, I guess, to us?
Absolutely. I think my feedback would have been, the one-on-one would be necessary. And then we had the one-on-one with Anna, and I can't remember the CEO that helped us right now, Anna, but we had several meetings. And I think that caveat was a huge success. I mean, getting the large overview and the group settings was great, but getting the one-on-one very quickly was very important. You may want to do that a little bit earlier, perhaps.
Fair enough. Thank you. So moving on to the next question. So if you could wave a magic wand, again, you did it. You know the struggle in terms of that balancing. If you go back to like I said, the way of balancing or weighing the value proposition of gains versus losses. If you could wave a magic wand and change the current REH statute, what changes would you make?
Unfortunately, mine was a little more directed towards the patient care. I think the 340B lost us, even though it was a financial loss to some extent to the hospital. The benefit in our rural health clinics is dramatic and was dramatic. And so what's happened is we've seen some of those patients that are not able to get the 340B through our rural health going to the FQHC. So I think that would be my magic wand and wish to get the 340B back for the rural health clinics.
So let's push a little bit more on that. So obviously that's a concern in terms of people moving elsewhere to maintain versus the revenue. That's a very key point. Right. And I think patient care is impacted by some of this, which is great. Did you have any, well, not great because of the statute, great feedback that you're giving us, just to qualify that statement that this is great. As it relates to inpatient swing bed, did you have any struggles there that you had to work through, or really not so much?
Not so much. We didn't have swing bed previously. And if you look at the historical data in 2022, 69% of our patients were observation. So if you look I came in the 4th quarter of 2018, our average inpatients were 8.7. And by 2022, average was 3.1, with the dominant being observation patients. So we were kind of a unique facility. We're surrounded in our location by critical access hospitals, 3 of them within 27 miles of us, 1 7 miles away. I think Kansas, if I recall correctly, the stats were that we have more critical access hospitals per capita per hospitals of any other state in the U.S. So we were seeing dramatic changes as a PPS. And so this came at the right.
Yeah, so you were PPS, not critical access, just to make that
Correct.
point, because you were surrounded by critical access hospitals. Okay. All right. Next question. So what advice would you give to a hospital who's considering the conversion to an REH? What would you tell them?
We had a different caveat where we don't have a hospitals program. Our rural health clinic providers also took care of the patients in the hospital. I think I would have spent a little more time educating them. It's kind of an interesting history. If we look back, Medical Center 12 years ago, whenever critical access hospitals came out first, applied and received the designation, but the doctors decided that that was not going to be the right move for them. And so they didn't take it this time. So I didn't foster trying to gain their input as much because I knew that it was a decision that we had to make. I think I might have gone ahead and given a little more consideration to making sure I had their buy-in better as the physicians that had been in the community for 25, 35 years, et cetera. In the end, though, they understood the significance and why we did it in right sizing for our community. So I think that would be the one thing that I did, that if you have a great relationship with your providers, make sure that you have them on board before you go reaching out to the community.
That's great. So you touched on this with the former question, and I just want to push it. So you already were doing a lot of observation.
Right.
So truly, was there any change from your clinical, from the clinical workflows? Obviously, inpatient admission was no longer an option. But
Right.
really, what can you speak to what changes the doctors maybe would have, or the clinicians, the PAs, whoever would have actually experienced as part of the transition?
So I think if we'd given them a little more training, they basically get a call from the emergency room doctors or PAs, and then they admit them. Whether they were observation or inpatient, I don't believe the physicians had really been trained or educated on. They just admitted everybody. Ironically, though, we were 69% observation, so it wasn't a huge amount. But for the first 2 weeks, we had to focus on training the doctors because they were still admitting patients that technically were inpatients that we would have to transport out. So that was one of the things on education up front. Our HIS department did a great job on the backside on making sure they were in the right status, if you will. But the physicians were not making those decisions as they should have been at that when we made the conversion. Am I making that clear?
Yeah, you are. And I don't want to put you on the spot, but one of the things as we talk with hospitals, through the conversion process, and we all know that inpatient versus observation, being a former, healthcare administrator myself, a lot of times inpatient versus observation comes down to a payment policy, and we're trying to get them in a status to maximize payment. And so I think one of the things as we work with hospitals, it's trying to identify how will patient care really change in my community. And so I think you hit on it, but I just want to explore that a little bit more. Has patient care, the provision of patient care, changed a whole lot? Obviously, the 340B, that's a viable benefit for patients to go elsewhere, all of that. But absent that, if you're thinking about the hospital alone, has patient care really changed a whole lot? If so, how?
No, I mean, overall, the patient care has not changed in my perspective. We have the same nurses. We're taking care of the patients in town that are applicable to be kept in our hospital. So I don't see that the care has changed in any way.
So from your perspective, obviously qualifying people for inpatient is no longer anything you have to worry about because it's not allowed. But obviously your providers are feeling comfortable with the people that are coming in and their clinical needs, that observation status allows them to meet those needs. Is that fair?
That is very fair. Yes.
So that, I believe, comes to the end of the questions that we had teed up for you, but we got a few more in through our registration. And so we want to provide the opportunity for those that submitted questions as part of their registration to actually hear Jeff answer those questions as well. And I believe we've had a couple more come in through our Q&A and through our chat. So one of the questions that was asked as part of registration was, have you experienced issues with patient expectations for care, expecting more than what the REH can provide?
I think the education up front and having the community meetings with Kansas Hospital Association and educating them helped alleviate some of that. But we did have some concerns. If you look from, I'll never forget, I had one gentleman that was convinced that with the change that his mother-in-law was being discharged because we were no longer accepting inpatients. And after a quick, 5-minute conversation with him, explaining exactly what we were doing for his mother-in-law, what her needs were observation and IVs, and that she didn't need a 2-day stay. So I think that was, I think we handled that relatively easily because we didn't have a huge with the upfront education.
So how did you identify? Do you think there's more patients that maybe have that concern? So and maybe you said it and I missed it, so forgive me if that's the case. How did you become aware of this gentleman's concern? And do you think he was the exception that maybe he reached out, or?
No, I think for whatever reason, when I went to, this was my hometown. So a lot of people knew me, and I was readily available to address concerns on Facebook. So I would never do that again. Facebook blew up. I was getting contacted all the time. And so I was just readily available to address them really quickly. I shared, we had 5,000 ER visits a year. Our average length of stay in the ER was 3 hours and 19 minutes. Historically, we had 1,000 patients. So the average of 24 hours could be easily offset by the emergency room patients. For some reason, a lot of people had that 24 hours that it wasn't an average, it was 24 hours and we push you out in the parking lot. So I made jokes with them. I told them we're not going to do that to your family any more than I would mine, and just was very open to communicating and any concerns like that. So I think that was an interesting caveat that I allowed them to be able to reach me easily and address them quickly.
Very good. So I just saw a question come through the chat, and I want to kind of tee this one up because it ties to what we just talked about, the clinical care that was, provided, all of that. So the question that came in is, we would like to simply take the lower fees and keep most inpatients as observation. Is that possible?
Repeat that question. Take
So
the lower.
so this is and I know we have to be careful because we're not giving medical advice here. So at the caveat, we can't give medical advice, but the question is, this hospital would like to basically take the lower fees or the improved fee schedules or the enhanced payment, but keep most inpatients as observation. So keep the patients in the community. But, keep them as observation versus inpatient. And their question is that possible?
No, it's not. Once you identify that the requirements meet inpatient, your insurance is not going to pay an REH that is only approved to accept observation patients.
Right. So it comes down to, are you going to fight to qualify them, or can they be safely kept in an observation status, right? So if they meet inpatient criteria, clearly require inpatient care, they have to go somewhere else. But if they don't meet inpatient criteria, then you can keep them in your hospital. Is that fair?
That's fair.
And I just wanted, your average length of stay has to be 24 hours, though. It's an average length of stay over the course of a year. And so to the point that Jeff made, if you look at your observation patients and balance that with ED, there is some flexibility that patients can actually stay longer than 24 hours. It's an annual average length of stay calculation that's important, obviously, that you can monitor that and stay on top of that. But it really does allow some flexibility, as Jeff had already pointed out. So thank you. So here is the next question that came in through registration, Jeff. How is the receiving trauma center agreement working? So one of the requirements is that you have a transfer agreement with a level 1 or level 2 trauma center. And so the question is, how is that receiving trauma center agreement working? I think the first question before that is, have you had to use that, as the REH, maybe that transfer agreement a little bit more frequently? And if so, how is that working for you?
So we actually are very close to Wichita, Kansas, that we have 2 trauma centers. So we got agreements with both of them. We have been able to get at least one of them accepting all patients in a timely manner. Now, I did meet with both of them in November. I retired in December, so I didn't get to fulfill and follow through on it, but talk to them about any special consideration that could be given to REHs. We were the first one in the state. We don't anticipate there being hundreds. There's only 100 and some hospitals in Kansas. And I said, is there an opportunity for us to have a priority? And so they were going to look into that. But I think, as we learn and, don't be afraid to ask questions, because they were very interested in that concept, saying, yes, we do understand that you have to transfer out inpatients. So we may be able to look at those in a priority system.
Great. So you've already touched on this a little bit, but I'm just going to ask the question and see if there's anything else that you would want to add to it. But can you provide lessons learned and recommendations from working with physicians and the community through the conversion?
Interesting enough, we're a small town, like I said. It's about 11,000, and I was from there, so I had some benefits of, a lot of people knowing me. But even with the education of talking about the REH and the need to right size and everything for the community, there were some concerns. That they built a new hospital 12 years ago. There's a 1% sales tax. A lot of people still thought that that was part of the hospital, and it's actually not. It's a city-owned building. It's held by the Public Building Commission. So the hospital itself was not getting any of that money. And a lot of people were confused that we were getting tax dollars and that we were making this change and downsizing the hospital instead of right sizing. So I think that was, important to make sure that we were communicating that with the taxes that were involved. The physicians I will elaborate on, I did, I think it's important to make sure that you have their buy-in before you go out and try to do community education, because they need to understand exactly where you're going and why you're doing it. So that was my hindsight to kind of look back. I wish I had spent more time with the physicians, but everybody knows in rural health, your physicians are working 18 to 20 hours a day anyway. So how do you squeeze in another meeting? Mm-hmm. They're not very excited when their CEO calls and says, can I meet with you on this? So.
So can we talk a little bit about what types of engagement strategies? So you've talked about meeting. Obviously, you're not recommending being available to Facebook, right. But like what other types of forums did you use to I would say educate? Were there specific forums? Like why would I would say the modalities? What did you actually use to do education, and what was the format, what was the content, agendas, all of that? Any insight there?
Yeah, so we did use our local newspaper to put out information and invited them to be part of the cohort group that we had on the communication side with CAHs and the Methodist Foundation. So we use that as well as radio. I went on the radio once a month for 3 months, just answering questions. And we also still had, the Facebook page for the hospital and the rural health clinics that we bombarded with information, education consistently.
Did you find that the community, obviously one of the things that we're encouraging folks to do, and through the Technical Assistance Center, we actually have some marketing materials and, put some draft decks together, because, and I think you've already mentioned this didn't just happen overnight, as it relates for the need for change there. And so did you get a sense that your community already kind of understood that, or did you find, along their journey, they were really surprised by maybe the need for such dramatic change? Like, were they aware of, I would say, the circumstances of the hospital? Or did you have to really, I would say, play catch up in terms of educating the community?
I think the community was aware. We were open records, so every board meeting, the newspaper was there, and there was a lovely article talking about all the money we had lost. So we did all that, but in addition to the other things, Janice, one thing I did was went to all the Lions clubs, Rotary, made sure that I was at every type of organization I could be, talking about how healthcare is changing and has been changing, and where we needed to go and why we were looking at this, and that it was going to make us viable and sustainable. So I think you just have to be very aggressive in going out in every opportunity to address and talk about it and answer questions. Very
good. Candace, did we get any other additional questions? I know there's some here coming through the chat that aren't necessarily geared towards Jeff, specifically about REH eligibility and other types of services. And we do want to provide time to address them. But are there any other questions that you've seen come through that we could put in front of Jeff at this time? Maybe one more question. You're muted, Candace.
Thank you. Trying to prevent background noise, and I keep forgetting to unmute myself, so thank you. Yeah, I think a lot of these questions are really technical questions, more geared towards us. Maybe one question that might, Jeff, you might want to weigh in on is, you mentioned earlier about the swing beds, and this is just probably more of a clarification. The question came in, since conversion, has it been a benefit to have your swing bed unit open, clarifying that under the REH, swing beds are no longer a part, and I think you had indicated that you didn't have swing beds before that anyway. Just thought that might be worth mentioning, is that swing beds are not part of an REH sort of conversion process. There's also questions about whether or not you can open after you've already closed. Can you become an REH if you've already closed? There's actually more specific answers to that question, a more detailed answer to that question on the FAQ. And I would encourage folks who have technical questions to reach out either to Anna, our team, or to access the FAQ on our website, which is rhrco.org.
I'll interject. I saw one come in, Candace, that was talking about OB. And yes, so we have the benefit that I said we had 2 hospitals close by. So we set up agreements where our rural, our family medicine OB doctors and our rural health clinics deliver at the critical access hospitals.
Okay.
So if they have, your community still has access to the pre and postnatal, and then they just go to the neighboring hospital to deliver. Is that fair?
Correct, and with our providers.
Awesome. So one last question, kind of going back to one that was asked earlier. What would be your final piece of advice to any hospital leader that might be on the phone here or might be on this call with us? What would your parting words to them be specific to consideration of REH?
Well, honestly, it's going to sound like an advertisement, but I'm going to tell them that we were doing all the due diligence ourselves, but getting a team with the Rural Health Redesign, reach out to them as quickly as possible, get involved and ask all the questions, because they are there to support you and answer them. And it was a huge asset to us as we were going through this process, Janice.
Well, thank you. And for those listening, we did not tee that up and we did not ask for that. That was just to try to close this out. I gave him one more question to answer. So thank you so much. We're here. We're learning a lot from you, Jeff, and from the leaders that have taken this plunge of testing something new. We certainly recognize it's not perfect, but it's a start. It's the first major policy decision that has come out of CMS, specific to trying to sustain rural hospitals. And so again, I just want to thank Jeff for being here, being willing to be here with us. And we will be doing a similar presentation actually at the American Hospital Association next week. So if you would like to hear it again or interact with us, we will be in room there at the American Hospital Association Rural Health Conference presenting on Monday. So with that, I'm going to turn it back to Candace and Anna to wrap this up for today.
Excellent. Thank you. Can you all still see my screen? Are you seeing resources and contact information? Great. As I mentioned, these slides are available to you along with all of these links. We've just kind of consolidated a few things that you might be interested in. If you want to explore more information, you'll get all of this information from our website. If you would like to follow us on social media, if you're not already following us on social media, I encourage you to do so. We routinely post information that's not only relevant to rural communities in general, but more specifically to those rural emergency hospitals. You'll see our website here, and you're welcome to reach out to us anytime if you have questions. I am going to be dropping into the chat a survey link. I will also follow up with an email after this, but we do encourage you to fill out the survey. We'd love to get your feedback on how we can continue to serve you and answer questions that you might have. So looking forward to, I will stay on if you want to grab that survey link before you hang up. Again, I'll follow up with an email after that. I just want to say an extended thank you to Jeff for your time. We really appreciate, we know you're in retirement. We love that you're able to share your experience. This is the stuff that it's all made of. Again, thank you to Anna and Janice for your work. We really appreciate your sharing your expertise with us, and look forward to seeing all of you and hearing from all of you as you go down this journey of exploring the rural emergency hospital as an option. Thank you, everyone.
Thank you.